Hi, good afternoon. I'm Dr. Gullberg. I'm a board certified intern. It's been in practice for about 28 years now. I want to go over a very common problem you're going to see in the office as well as the prompt care setting, even in the ER, obviously, in the hospital. Patients that come in with chest pain. Sometimes we have to do a lot of detective work for chest pain. It's not always straightforward. I want you to think about the differential diagnosis of chest pain before you go into the room, what questions you're going to ask, especially if you're a medical student or you're in training. Differential diagnosis for chest pain is going to be, first of all, musculoskeletal. Was there trauma of any kind? Does the patient have fibromyalgia history? On clinical exam, do they have extreme tenderness of the costal condylar junctions? That's really going to kick it off. Usually, musculoskeletal chest pain is the costochondral junction is very tender on palpation, and just breathing makes the costochondritis extremely painful. So musculoskeletal is by far number one to rule out. Pretty simple on clinical exam. The second cause, of course, is pulmonary. Does the patient have tachypnea? Does the patient have tachycardia? Is the patient having an acute pulmonary emboli with a pulmonary infarction causing the pain? Does the pain get worse with cough? Is there cough associated? You'd think then, of course, about acute pleuritis or pleurisy or something actually in the lung. And, of course, clinical exam is going to be helpful here, looking for dullness, looking for a pleural friction rub, as well as appropriate blood work, checking D-dimer, chest x-ray, CT scan, or VQ scan if necessary. Number three, cardiac. Is the patient having accelerated anginal syndrome? Are they having a myocardial infarction? Obviously, we're going to look at an EKG. We're going to take a good history, see if it's related to exertion. Is it centered over the left side of the chest? Is it radiated under the jaw or down the left arm or into the back if it's a posterior problem? We're going to check troponin levels, CPK appropriately, and of course electrocardiogram. But the patient may have pericarditis as well, so the chest pain may be more atypical and sound almost musculoskeletal. We're looking for a pericardial friction rub, especially with the patient sitting forward. The fourth thing we want to think about is an esophageal injury or esophagitis. This can also mimic angina pain, can cause a dull ache in the chest, sometimes relieved with nitroglycerin, but of course it's usually affected by swallowing. So think about esophageal problems. The last thing we want to certainly think about is an aortic aneurysm of usually the thoracic region, obviously. May show up on chest x-ray, may not. Sometimes the pain is very sharp, radiates into the back, and a CT scan of the chest or an angiogram is going to be necessary. So I want you to think about all those 6 different causes for chest pain just in 30 seconds so that you can review appropriate history, appropriate physical, appropriate chest x-ray, appropriate cardiogram, echocardiogram, CT scan, blood work, all that's necessary to make the diagnosis. Thank you, Dr. Gullberg, signing off.